Good evening, friends. Today's concept is on one of the most important thing in pulmonary critical care. So let's start. This is on oxygen-induced hypercapnia. I have got a case presentation here. So I'm going to read out this and then I'm going to dissect each and every part of it, and then I'll explain what is the reason behind what is happening underneath. A 65 years old woman comes to the emergency department because of a 9 hours history of severe shortness of breath and worsening of her chronic cough. The cough is productive of large quantities of sputum, and she has hypertension and chronic obstructive pulmonary disease. So we already have the diagnosis here. Now, COPD is consist of two things. So one is emphysema, the other one is chronic bronchitis. So of which the two of this both we can differentiate both the with presence of cough with sputum, because emphysema doesn't have sputum, whereas chronic bronchitis has plenty of sputum. Yeah, so this should be a case of chronic bronchitis. So she has past history of hypertension and chronic obstructive pulmonary disease. She has smoked one pack of cigarette daily for 47 years. So this is a huge pack years. This is the result. Smoking is one of the most important cause for COPD. Current medication includes thiotropium, bromide, albuterol, and hydrochlorothiazide. So hydrochlorothiazide is for hypertension. Albuterol is a SABA, short-acting beta agonist. Thiotropium bromide should be a long-acting beta muscarinic antagonist. So, and albuterol is a SABA, short-acting beta agonist. So both are bronchodilators, whereas hydrochlorothiazide is thiazide diuretic, which is for hypertension. So here you can see it is treating both. So the temperature is 37.1 degrees, pulse is 72, respiration is 25. So this is a high respiratory rate, so trachypneic, and blood pressure is 146/95. So the hypertension is not being well treated with this drug. So pulse oximetry on room air shows oxygen saturation of 82, which is relatively low. Examination shows perioral cyanosis, subcostal retractions. We'll see why this happens. Expiratory wheezes are heard over both the lung fields. The patient is given albuterol and intravenous methylprednisolone and receives 100% oxygen at 10 liters per minute via face mask. 8 hours later, she becomes somnolent. She is not responsive. What is the most likely explanation for this sudden deteriorating situation? So first we'll see what is the case, and then we'll understand what is happening, and then I'll explain you what is the reason behind the condition, reason behind the somnolent and not responsive patient for this case. So here you can see this patient came to an emergency room with severe shortness of breath and chronic cough just 9 hours ago. So she already has COPD, and now she has an exacerbation now. So this is a COPD exacerbation. Now exacerbation, and it can be because of any infection, but in this case it is not, because the temperature has not raised and vital seems to be very normal. For a COPD, trachypneic is very normal. So this is an exacerbation of unknown etiology. We don't know what is the reason. Now on examination, you can see there is perioral cyanosis. So we have cyanosis. So blue is discoloration of mucous membranes and skin. So, and there is also subcostal retractions. So we'll know what is subcostal retractions. So now chronic bronchitis, if you see the airways and the alveoli, so there is mucus secretion along the respiratory tract. So which the name itself is telling you COPD. So O is obstruction, and it is a pulmonary disease. So in the lung, the obstruction is because of this hypersecretion happening at the level of the airways. So which results in air coming inside, but it is not letting it out. So which results in accumulation of air. So this is the result. This is a reason for increased reserve volume for the lungs. So this is the reason. Now because air is coming in but it is not going out, so it is also accumulating CO2. Now here you can see the mucus secretion can come down into the alveoli and it can stasis here, which can dilute the surfactant. When there is a dilution of surfactant, there is increased. Normally surfactant will reduce the surface tension. Whenever there is dilution of surfactant, so which means the surfactant concentration has reduced, which results in surface tension will increase. So which will increase. So by now you should know this is under the Laplace law, 2T by R. So whenever surface tension increases, the radius will be reduced. So we are talking about the radius of the alveoli. Right, so this is the reason. So this is the reason the alveoli has shrunk. So this is the normal one, and if you see, because of the shrunken alveoli, it will become like this. So it is same for respiratory distress syndrome and of any cause. So which causes shrinking of the alveoli. So now your lung, which is outside, guarded by the coastal your ribs, will try to go out for inspiration, but this will not allow because it is already collapsed. So there is already negative intrathoracic pressure which will suck the in between skin, which will be seen as subcostal retraction. Also, this is a very prominent finding which you can see on the physical examination. And because there is this alveoli are collapsed, the blood supply underneath is also impaired because there is no exchange of gases happening. So this is arterial and venous. So pulmonary artery and pulmonary vein. So deoxygenated blood is got, but it is not oxygenated because it is all impaired because of this collapsed alveoli. So that is the reason it have been the patient is having cyanosis and subcostal retraction. So and then you see expiratory wheezes are heard all over the lung fields. So which means both the lungs, alveoli, the respiratory tract has plenty of secretions. So this is the reason for having subcostal retractions. Sorry, this is the reason for having wheeze throughout the lung field. So if you take the lung and divide into 3 sections, so you see first upper, middle and lower, and you listen to the wheeze because of this. So because of this, which means so the infiltrates exudate has been here and here as well. So because of here it is collapsed. Okay, so this is the reason for expiratory wheeze heard through both the lung fields. The patient is given albuterol and then prednisolone and receives 100% oxygen. So when you see ACOPD patient and then you tend to be curious and treat this patient with giving high oxygen because initially and you think it will actually resolve the condition, but it will deteriorate because of something called as oxygen-induced hypercapnia. We'll see what is the reason for that. So the first, there are three proposed theorem for oxygen-induced hypercapnia, of which is the most important one is ventilation perfusion mismatch. Now let's suppose we have an alveoli, and then let me depict. So this is a venous blood flow, and then this one is an arterial one, which becomes oxygenated and goes as arterial blood, right? So normally there is exchange of gases happening. So which goes out is carbon dioxide, which comes is oxygen. So this should be pulmonary artery, and then this should be pulmonary vein. So now the exchange happens in this fashion. So this is the ventilation which happens within the alveoli, and the one which happens within the blood vessel, the flow of blood, is the perfusion. Now what happens if you take a normal lung, and you can see, let's take three groups of alveoli, and you will be able to understand. Now, because gravity is more at the bottommost part, there is more perfusion here. When you see, there is more ventilation here. So more ventilation here. So if you take V by Q ratio, V by Q. Let me show you in a proper manner so that you won't get confused. So let's suppose we have blood coming, the venous blood here, and then which becomes arterial. Now because in the middle group there is equal perfusion and good ventilation and good perfusion, so this should be 1. And as you go up, there is less blood supply because all the blood is gravitating at the bottom. So because of that, it becomes relatively less. So it will become relatively less, which will increase the value. It will be beyond 1, right? It will be beyond 1. And let's suppose here in the bottommost part where there is more perfusion, this will result in relatively less value. VQ there is less than 1. So this is what happens in the lung. So now you should also understand something called carbon dioxide induced vasoconstriction. Now normally in the alveoli, whenever there is carbon dioxide, more carbon dioxide, let's suppose in COPD, which causes the vessels in the lung to vasoconstrict. So normally you might have this is called carbon dioxide induced vasoconstriction. Normally carbon dioxide tend to vasodilate anywhere apart from the lungs. It causes vasodilation. But in the lungs, it causes vasoconstriction. You can tell me what is the, do you think, is it advantageous or not? If you can type uh, uh, in the chat and tell why it is advantageous. If so, if it is not, then tell it is not. Why is it is not advantageous? So I'll mm, for the moment I will tell you that carbon dioxide causes vasoconstriction in the lungs. Now this is the reason the blood doesn't go forward, which causes resistance to the heart, because this is pulmonary artery. It backs down and causes something called as cor pulmonale, which results in right heart failure. Okay, so now, so what happens in the first mechanism for induced hypercapnia is, uh, uh, let's take the same diagram which I wanted to show you, and then I'll tell you why this happens. So let's take three group of alveoli, so upper, middle, and lower, and then I'll depict the same one. Uh, so whenever there is obstruction in, like in COPD, because it is COPD, which means chronic obstructive, which results in chronic retention of carbon dioxide. So whenever there is chronic retention of carbon dioxide here, because of obstruction, because of any obstruction, it can be because of hypersecretion of mucus, or it can be because of any reason that results in carbon dioxide retention, which causes vasoconstriction. Now, when this patient with COPD exacerbation comes to you, and then you tend to give a high level of oxygen, percentage of oxygen, and then when it goes inside the alveoli, it tends to vasodilate, because I told you just now, because carbon dioxide causes because you can see in the whole lung there is ventilation is more here, and there is more perfusion down because of gravity. Now because ventilation is more here, the upper lung area will be more oxygenated, that results in vasodilation. So whenever there is vasodilation here, there is plenty of blood which is going to the upper group of airways. This results in all the blood which is, if you have vasodilated, the blood should be coming from the other groups, so it will go upwards, it will go towards this, it will compensate for the vasodilation which will accommodate the blood here. Now, because blood has deviated there, the blood is no longer in this group of alveoli. So just think about it. So V by Q. Now you don't have perfusion in the lower group. So whenever there is no perfusion, and then you will be having VQ mismatch. So your V by Q will be more than 1, which means it is a dead space, which means there is ventilation happening, but there is no perfusion at all, which is useless, because there is no blood to perfuse at all, right? It is no longer, there is no blood to perfuse at all, so this is totally wasted. So because only a small segment of the lung has been oxygenated, the other two segments will be predominantly carbon dioxide filling with carbon dioxide. So this is the reason for hypercapnia. This is the most important reason. So this is the VQ mismatch. Now there is another mechanism. It is Haldane's effect. So it is Haldane's effect. So which means if you take an RBC and then if you can see, whenever there is oxygen given, there is release of carbon dioxide through the hemoglobin. So the hemoglobin will be releasing the carbon dioxide inside the blood vessel. So this carbon dioxide will be predominantly staying outside, which will increase the CO2 concentration. So the vice versa is also right. Whenever the RBC comes to the tissues, the oxygen is released and carbon dioxide is attached to the carbon dioxide is attached to the RBCs here. So this is at the level of tissue. This is at the level of lung. So this results in hypercapnia. This is the second explanation, or you can say theorem for hypercapnia because of oxygen. So the third explanation would be because of respiratory rate. Now, normally when carbon dioxide is more, even you can see in the case the respiratory rate was 22. It was 22. Respiratory rate is 25 cycles per minute. So if you can see, it is 25 per minute. So this high respiratory rate tachypnea is because of CO2's stimulation on the respiratory center, which is present in the medulla oblongata. Right? You have midbrain, pons, and medulla oblongata. So respiratory center, because of stimulation, this increases the respiratory rate through the phrenic nerve. So now, because there is more carbon dioxide, that results in increased respiratory rate. But whenever there is more oxygen, whenever you give the oxygen in the initial period, which will cause the respiratory rate to shut down, which results in decreasing the respiratory rate, and then it will go back to again 12 to 40. This results in decreased respiratory rate, so which causes increased carbon dioxide retention. So these are the three most reasons for oxygen-induced hypercapnia. So the first one is VQ mismatch. The second one is Haldane's effect. The third one is through respiratory rate. So because of these three mechanisms, there is hypercapnia, and this can be seen through the ABG. Despite the question doesn't has ABG, you will be evidently seeing ABG which is having acidotic. So normal pH would be 7.35 to 7.45. Right, now it will be below, and you will be seeing this is because of respiratory acidosis. So your PCO2 will be normal, should be 35 to 40. So it will be beyond 40. So this is how you will come to know this is in the respiratory acidosis, which is very easily seen in the ABG. Now you should be very careful, and we should always maintain an oxygen saturation of 88 to 92%. We should never keep this COPD patients on 100% oxygen, so which will cause oxygen-induced hypercapnia. So this is the reason behind it. Thank you.